Hello, everybody. My name's Ira Kirschenbaum. I am the chairman of Orthopaedics at Bronx Care Healthcare System and also the editor of the Journal of Orthopedic Experience Innovation. Tonight, we have a tremendous faculty and a fascinating discussion. OSSIO, integrative implants and the use of sports medicine. We also have a guest moderator, someone who needs no introduction, but I will ask him to introduce himself. Nirav Amin, I want you to take over from now, and I will pipe in with some questions periodically. Nirav, you there?
I am. Thank you, Ira, for having me, Oscar, and Brandon on the call. I wanted to thank you for actually hosting us, you and Beth, and then most importantly, the OSSIO team from the leadership team to kind of having us. Let me walk through a little bit of the background of the OSSIO. Brandon, you and I have been through this journey probably as early as can be when we started. Walk me through, Brandon, what got you excited, right? So they have a material play. They come into your OR. I'll kind of give you a little bit of my background and then I'll pass it to you, Brandon. And then Oscar, actually, I'll pass it to you as well. My play was I saw the material. I've known Brian Jones, who runs the med ed side of things for them. I've known him for a while. He was at a small booth in a corner and they had a small foot and ankle product line, to be fair. And then they showed me the slide of the material being this biocomposite, what I'll call it, a biointegrative material that's as strong as metal. And the first thing I ask them is, when can the rotator cuff anchor come? So fast forward a few years later, they come with the full rotator cuff anchor. And to be fair, that's where my journey started, and then expanded through this profile that will walk us through. Brendan, what about you?
Yeah, actually, so I've been using the Osseo for a little over 2 years, maybe closer to two and a half almost. But actually, so I was getting ready to go to Academy. This is back when it was in Vegas several years back, and a foot and ankle colleague that I work with was like, "Hey, go check out this Osseo stuff when you're there. I think you'll be interested in it." And I didn't know anything about it at that time. I'd never seen it, never heard about it until a colleague had told me. And so I rolled up to the booth, kind of found them. They're off in a corner. Poor guys like they put Osseo in the corner. Nobody puts Osseo in the corner, but they did. And started looking at the implants and was like really intrigued, honestly by the compression screw. And then at that time, Nirav, they had just come out also with the rotator cuff anchor as well. So I was able to kind of see both. And the first thought that came to my mind, I do a fair amount of knee and shoulder, a lot of TTOs and different things. And with it just was like, oh, wow, would this work in a TTO? And take away the hardware pain that the folks get. We've only ever used metal there. Would this work? And I was, honestly putting it in my hands and like trying to break the little bars that they had. I was hurting my fingers. I'm like, all right, well, this stuff's definitely strong. I mean, as you guys all know, we've probably collectively put in every single biocomposite, you name it, anchor on the market and broken all of them from different applications. And so I was very intrigued. But really the question still becomes like, does it work? And so, I vowed to give it a shot when I got back on my next TTO. And if you want to, I guess you can roll the slides now. You can put up my slide deck because it kind of takes you through that little evolution. But my first plan with my first TTO was to like, well, I don't know if I trust it yet, right? I mean, we're all skeptics as we should be, especially with any new technology. And I said, look, I'll try the Osseo screw, put that in, see how that goes. But my plan is to put a metal screw second. And lo and behold, the first one went in, so well. The compression was awesome. And I just said, I turned to the rep and I was like, I don't know, like I don't know why we don't put the second one in. Let's do the second one. And so it was, this was actually that patient. This was the N of one, or the beginning, if you will, of what I think is going to become the gold standard in TTO surgery.
So you can see the
Um,
slides, right, Brandon?
yeah, I can. Yeah, and this was your classic, young, injury pattern. It's got all the characteristics of somebody who, not just has instability but also, malalignment. And so you can go to the next slide. And if this is what I used to do, and I say used to do because I haven't done it this way in over 2.5 years, and have no plans on going back. But so, taking back to that case was, yeah, the second one, the first one went in so well, let's do the second one. And, it worked. And, literally lifting the tuberosity fragment that I'd shifted off, try to, lift the tape, off the table, and it's holding together. There was good compression and it was awesome. If you go to the next slide, kind of shows what that case was. This was that first case, initially it's guide pin, over drill, tap, place, measure and place the screws. And the cool thing, sorry, I've got dogs in the background. But the interesting and cool thing is like you can still kind of see them on fluoro. If you look at that bottom right picture, you can kind of see the faint outline of those screw threads right there. Yep. And that's with both. That's the final fluoro shot in there. And that was with the original 4.0 cannulated compression screws that OSSIO has. Now, if we go to the next slide, what's happened is I wanted to, these are, this 6-week post-op films. Usually by 6 week, I'm getting X-rays. I'm taking them out at that point. If it's showing good healing, these patients typically at 6 weeks really have no pain. They're ready to kind of get moving. I've allowed them to weight bear as tolerated, immediately out of the gate in extension with a brace. And then at this point, they're allowed to transition out of the brace. And if we go ahead and look again, the next slide over. This is a patient that had come in after there. I usually get them at 12 weeks as well, but this patient came in at 4.5 months, and it was interesting because even at 4.5 months, there's like complete remodeling of the entire tuberosity area. And I love this picture because you can still kind of faintly see the screws and where they're at, but the whole bone is like totally remodeled. And so what I then wanted to do was like, all right, this works, and these patients, but let's see how they do overall, really, because what's going to change my mind to fully commit to this is do we get unions? Do we not have non-unions? Ultimately, do we have to take anything out, or do they have any hardware related pain? And so if we ended up collecting our own data from my institution and looked at all my cohort from both pre and post OSSIO, and we had a total of 62 TTOs, 44 of which were metal. We had 18 of the compression screw. We've got our different demographics and stuff there. Next slide. These were all comers. We didn't separate them for based on injury patterns or anything. And our overall length of follow-up, obviously it's shorter in our OSSIO group, but as of now, I've got my first patients are over 2 years. But all of them achieved full union by 6 months. We had zero removal of hardware in the OSSIO and integrative group, which was a significant p-value already. We had no recurrent instabilities. We had no revision surgery needs. The IND was actually one little superficial wound dehiscence in one case, but because of the number difference, it looks like it's a higher percentage. But patients are happy, and so I think we've proven effectively that this works. We've lowered our risks with our patients. We've negated any need for hardware removal. And honestly, I think when we talk about with our patients, like, hey, do you want to do metal, or do you want to do these screws? And I take them through that process and explain, that this is integrative. It's made of the materials of bone. It's hard as metal from time zero. It's basically integrated within 18 to 24 months. I've yet to have a patient that looks at me with anything other than I want that. Like, why wouldn't I want that? And I don't blame them. I would want it if it was me. And since December of 24, we've now got the next version of this. I think this is a kind of, again, from a, all of us like playing with toys, and I look at these as like little kind of fun things to play with. But we now have a 4.5 millimeter trimmable threaded nail. The nice thing about this is it actually is self-tapping, so it takes away one whole step out of the whole surgical technique. The driver itself is adjustable. It telescopes within itself. It has the driver itself travels all the way down the full length of the nail. So you can actually, if you like to use fluoro in the OR to assess length and see where the screw is, that telescoping nature of the driver allows you to do so. You can actually cut this, which is a simple saw blade on the back table. It's actually kind of fun. And then the self-tapping aspect of it is you use a little the old school pencil sharpener and twist that thing in there, and it reshapes the tip of the the implant, and there you go. And I've used these now for the last 6 months since they came out in December, and it's working like a charm. We haven't had any changes in our outcomes or anything like that. So this for me has revolutionized my approach to this. Surgery itself. I think the impact with our patients is immense. I think we've improved patient care by using this for TTOs. The rotator cuff is another fabulous. I mean, I use it. It's my lateral anchor on every cuff I've done since 2023. So, put in hundreds and hundreds of those and love it. The other thing is, real quick before I pivot back to you, Nirav, is that I've yet to break any of these things, and I've used them. The rotator cuff anchor, I've used it in all sorts of places in the body, including on hard, dense tibia as backup fixation. I have videos of it squeaking, and when we hear that, we're like, oh my gosh, this is going to break. Haven't broken. These TTO screws haven't broken. And anyway, it's been, I think, revolutionary in our space for sports medicine, and yeah, it's in no lytic lesions. We have a cohort for our rotator cuff that we are keeping a registry database on, taking X-rays at different time points, not seeing any lysis around any of these implants as well on X-ray. So it's doing what it's supposed to be doing.
Yeah, and I think I'll walk you through a little bit, right? So, right, I think you're referring to these, right? So
Yeah,
historically, you have these options
yeah,
available. And Oscar, I'll kind of lend to you, right? So let me kind of back up a little bit, right? So you've seen the spectacular data by Brandon showing that. Oscar, did any of these time points here, right? Like, so when you look at a label and you look at an anchor material, I think everybody quantifies a strength, right? So they say it's strong as metal or it reforms. Anything appeal to you here, Oscar, that said, hey, maybe, hey, I'm going to gravitate towards this material. Hey, this is really enticing. Anything here that kind of gets you going?
Well, I could tell you, you guys, I had very similar story as to how I started. I was at the academy in Vegas, that little booth, same thing. And one of my reps, came up to me and he worked in the foot and ankle space and said, hey, he was talking about the bony formation, the integration, and obviously that is appealing, and that the implant goes away. I mean, those were amazing slides, Brandon. It's amazing that you don't have to go in and take out the metal. But for me, that drew me in. I was having a little trouble with my knee surgery, putting in the internal brace, and so when you were getting down towards metaphyseal bone, and I kept breaking anchors, and you know nothing is you know, more irritating than, you've gone through this whole case, you've got everything and kind of the last step, and, you tap, you do everything, and the anchor breaks, and it was breaking more and more. And I said, there's got to be something out there where there's a stronger um, implant that is made for metaphyseal or even diaphyseal bone as you get down. And sure enough, I went to the booth and I was looking at all the implants and looking at the anchor, and I said, "Oh, I can use this." And this was I literally, I think the frustration probably had happened 2 days ago, and I was ready for it. So the stronger than cortical bone is really what brought me in, and then all the other properties add, and I started using it, and sure enough, it went in so much easier, you know,
Yeah, and Oscar, I'll
very
give you
few
I'll give you
problems.
an interesting tad bit, right? A sad comment, side comment. So we were at a meeting last week, I believe, in Scottsdale, and I took a poll. So there were, I think, about 30 surgeons in the room, and I said, "Hey, how many of you have done rotator cuffs where you've broken more than 5 anchors of one company on the lateral row?" And 30 out of 30 surgeons raised their hand. And then I asked the question, how many of you have broken more than 2 anchors in a case when it's hard bone and you tap and you're trying to figure out what the right anchor body to use or what tap to use in that setting? And everybody raised their hand, all 30. And then I asked the same question and I said, how many people in the audience combined in their historical utilization of OSSIO anchors laterally have broken more than 5 anchors? Nobody raised their hand. So I said, oh, that's interesting. Let's go down to 3. And nobody raised their hand. And then there was one person, openly me, who said I had broken two anchors. So it's a fascinating thing when you talk about that, right? The frustration that surgeons feel when they're putting anchors into the tibial bone for backup fixation on an ACL. It's a real frustration we all feel. You put the anchor in, half the anchor body goes in, and then it breaks. There's nothing worse than that, right? In that setting.
Yeah.
I'll go to this, right? So we talk about this, and I think for everybody on the call and the in this webinar who doesn't actually understand the material of Osseo, let me even back up a little bit, right? Historically, the question always gets asked anytime you use a new material, oh my God, am I going to have some level of some microscopic or some foreign body reaction taking place? I think the porcine mucosal error in the rotator cuff always makes everyone very apprehensive in that space. I could rest assure you, I think if I'm not mistaken, and the leadership can maybe answer this if they're on the call, I think there are over 10,000 cases in of now one reported inflammatory reaction. And so what it is the materials that it's made of are actually an osteoconductive bone void filler. And the makeup of it and the kind of secret sauce to it is a combination of this, right? So silicon dioxide, silicon oxide, calcium oxide, magnesium, and all these materials. And then what really happens is, as the polymer comes through over a period of time and the pH resolves, you essentially get this hydrolysis that takes place and the polymer clears and you actually get this bony formation over time. So that's what Oscar and Brandon are talking about. So when you look at Brandon's slides and it's 6 weeks, you're seeing this integration, you're seeing some of these polymers break down and you're seeing the bone formation take place. The question becomes, what do you do with this? So I think Oscar alluded to, and I'll let you comment on this. Oscar, have you felt this in clinical practice, right? So there's the market leaders, right, that we currently historically have used, and it sounds like you've transitioned over. Have you felt the pull-out strength be better? Or have you tried testing it? Like, what is your kind of telltale sign? Sure, I can show you all this kind of data, but what do you use clinically, Oscar, to say, hey, this anchor seems in my hand to perform better than what I'm historically used to?
Well, number one, on the backup on the tibia for ACL, as we talked about, I'm able to get the anchor in. Doesn't break, holds, able to get it in. When I've used it in lateral row, in the opposite, number one, you get it in, but then when you pull on it, crank on it, listen, I've seen soft bone and it's soft enough. Doesn't matter what you put in there, you got to then use your other tricks. But I do test. I pull pretty hard when I check because I'd rather it fail at time zero when I'm holding it than fail at 6 months when your patient is now complaining of pain and you get that MRI where we've all had it. The rotator cuff's pulled out. There's an implant flying around. So I mean, clinically, I feel it every time.
Yeah, and I think most of the anchors, right, Brandon and Oscar, I think you'll agree, are made of some competition of this, right? Some PLDLA, some calcium biphosphate, and some component of this material, right? And I think all of us will kind of agree this material has a different propensity and a different chemical makeup that makes it a little bit unique in this setting. Let me ask you guys a different question. If you have used Osseo, and have you had to, number one, go back in a rotator cuff? Unfortunately, that failed for some reason. And if you have, tell me your experience. And if you haven't, it's okay too. But if either of you guys had a rotator cuff where you've had to go back for osseo anchors for any odd reason, Brandon or Oscar, either?
I actually haven't. I haven't had that.
Yeah, I have actually had a second look on a cuff for a biceps issue, and then went up top because there was wanted to kind of clean out the bursal space as well, and could very faintly see. It's unfortunate I didn't take the pictures, but like very faintly kind of see where the outline was, and palpating with the probe. And I know that we've all kind of seen other biocomposites, anchors of whether it's like interference screws on ACLs or let's say different anchors on the shoulder. And when you go to they look like they're like a normal solid structure, and then you go to touch it with like a probe or whatever, and it just kind of is like mush. Like this was just the same type of strength, and hardness that it felt like, at time zero putting it in. So, and I think that patient, if I remember correctly, was about eight or 9 months post. the index procedure. So still not enough for necessarily something to fully regenerate, integrate. But a lot of these other materials have just they look like they're there and then they just kind of just crumble and fall apart. But they're never integrating. And I think that at the end of the day, they're never becoming the bone that they say they are. This has been something that I've seen, both on images because I'm following at least a lot of these TTOs, and you're seeing these things disappear over time. And you can even make the argument that, as opposed to using metal implants or metal screws that are never going to bridge anything with what we want, it's always going to be metal. Like this is actually going to bridge with something like you can look at the ladder J application. It's going to bridge with something that's going to turn into bone. And maybe that actually aids in preventing a non-union, right? So extrapolating that to that field, but
Yeah, Brandon, look, you make a great point, right? So, like, if you think about it on your TTOs, right? If you look at the far left of restore, you're putting the screw in. You actually make an excellent point that's probably understated the most with OSSIO, the integrated portion of it. So it's actually FDA approved for the biointegration material of it, right? So to have that label is very unique and kind of gives it a unicorn type ability of material that others don't have. I think all three of us on the panel agree when we put the implant in, we're at the far left of the screen, which is restore. I think
Mhm.
between times 0 and the 2 years is this regrow rate to then you're back to normal anatomy. I think you make an interesting point when you say anytime when I do BTB ACLs, for example, right? You put an ACL screw in biocomposite on both sides, you get great fixation, and then let's say you go back for 2 years, God forbid if there's a failure, and you look at your x-ray and you don't think there's tunnel lysis. And the moment you put your tibial femur in, suddenly it's just this wide open cavitarious lesion where the screw went in, right? And we've all had that experience. And I think there's that a real component of the biocomposite material that is not played in the favor of what we're all hoping for historically in the past. So let me ask a different way. So this is me. These are all these punches that are available. They do have a punch that comes with an anchor. I'll be honest, I under tap. Brian, do you under tap your lateral
yeah,
row?
I actually actually had some special taps made, some punches, not taps, punches made that are undersized. I mean, if you look at, primarily we're using this on, whether it's medial or lateral row. I think medial row, under punching might be a little, you're going to get harder bone up top. But on that lateral cortex, a little softer. And so I under punch, honestly, I kind of look at it as let the anchor do the work because this anchor can do the work. It's again, saying it's hard as metal sounds cliche, but honestly, having put hundreds of these things in, it literally it lives up to that. And so I let it do the work. And so under punch, get better fixation. And so yes, to answer your question.
Yeah. Oscar, you under punch or you go line to line with the punch they provide?
I've gone line to line, so I use the one in the box.
Yeah, and I think there's no pro or con. You can go either way. Obviously, if the bone is incredibly hard, they do provide a tap, right? So let me kind of show you a
I
real
will
life.
say real quick is that if you're doing subscap, that lesser is a lot harder bone. I would probably use the standard punch for that application.
Well,
So
in the tibia, I actually, there's been you get some tibias and it's real hard if you're, further down, if your actual tibial tunnel, I sometimes revisions, you're going a very long tunnel and now you're in really hard bone. I've even gone line to line. I always tap the tibia. So you guys were just saying punch, but the tibia, I always, uh, I always tap as well. And I've gone to the bigger 5.5 tap.
interesting. Yeah, and let me share with you guys, please tell me and I'll hold the video, right? So for me, right, this is a lateral anchor going in, tips or tricks, right? So you see the sutures going in on the right, right? You can see them coming in. There's the eyelet in the hole that we punched. Here's a key part. You can start tensioning the suture if you want. You don't have to. When you mallet this anchor in, what's really important is you see the actual body come in. If you actually turn the top before the body comes in, then that actually will spin on itself. So you actually notice I actually mallet past a little bit of the first pitch of the body. And before you turn the pair, as I call it, or turn the top, you actually can pull the suture to get tension out. And if you pull so hard, one of the downsides is the pull out strength is so good. If you cleat it as hard as you can, and then you try to tap it down, it's actually over tensioning your suture. So you got to be a little bit careful on that. Any thoughts, gentlemen, on this? Like any other tips or tricks here? But I think the lateral anchor is like any lateral anchor we've used in the past. I think it's very reproducible, very easy to use in your OR, and it gives your patients a better material, to be fair. Any other
Yeah,
comment?
I think you mentioned probably the biggest pearl there is that you want to mallet or tap in that first set of threads that because otherwise it can not, it's not as aggressive as an initial bite when you start to turn it as the screw that, most people might be used to using that's similar to it. So you just get that first little bit of thread in with the mallet. You'll hear a little pitch change. You'll feel that. And that's when you start to roll with the screwing it down.
I think one of the things is the ease of use. Like it hasn't been, for anybody who's on this call are going to look at this when you first use it. This isn't one of those, the lateral row on the rotator cuff isn't one that takes a long learning curve. It's, you make sure you just punch it in, get it in a little bit, and then it works and it works reliably. The
Yeah.
reliability is one of its keys.
And Oscar and Brian, Brendan, I'll kind of point you guys in the direction. Look at the marrow cells coming out from the lateral row, right? So it doesn't create this vacuous closed channel loop. You can see the marrow cells pouring through this. I even took a video just to see it, right? It's really interesting how it's just kind of pouring in, right? Let me kind of show you a little bit, right? So here's an ACL repair, right? I did listen to Dee Felice's talk the other day, so maybe I'm not going to use the luggage tag that I used in the past, but this is a collagen-based suture. And then I put an anchor in, and you could see off the wall, right, Sherman. So look, if you look at the data, maybe this is a repairable. Look, I'm not going to get into the debate of if I should have repaired it or reconstructed. That's a whole different animal discussion. But Oscar or Brandon, have you used it in an ACL repair? If you've done it, Brandon, I know you're not as fond of an ACL repair, right? But you've done some in the past. Oscar, I don't know if you do ACL repairs or not, but I do some ACL repairs. Historically, I worry if I'm going to use a biocomposite material. If it does fail, I want something that goes away so I can do a primary ACL reconstruction. Any thoughts on that, gentlemen?
Yeah,
So,
I've used it on the backup fixation, for a couple of repairs that I've done. Like you said, I probably lean still heavily more towards reconstruction still. But after seeing, a couple weeks ago, the wizards of ACL repair kind of present their data and their techniques, it's definitely enticing, to kind of stretch some of those limits.
Oscar, what about you?
yeah, I'm the same. I'm, reconstruction most of the time, but I've certainly I've done plenty of repairs. I'm very strict in my indications, but and I have used OSSIO for the same thing you said. Hey, you know, we're trying to learn about repairs, and if they fail in the future, what do you rather deal with? You
Yeah,
rather
yeah.
deal with native bone and it's almost like a primary, or dealing with these big, I mean, I think that's a no-brainer. And really this, and I go back to the strength too, the ACL takes a lot of forces. You want a strong anchor, and you want one that can hold those forces. And I think that will be not only just that it turns to bone, but that it's going to be important in increasing the success rate of repairs.
Yeah, great points, Oscar and Brandon. Great points. I'll turn to you. And so I think you could see this is a subscap tear. You could actually see the mid body, right, torn off a little bit on the C side, right? I hope most of us on this panel, right, will say there should be some level of addressed subscap repair in this setting. So I'll tell you, I use a luggage tag to repair the subscap. I tag the biceps tendon into the same thing, and I put it into a 475. So Oscar, you mentioned you use the osseo tap. Here's the osseo tap coming down right here, right to the first black line. Question for both guys. So I do a lot of subscap repairs. I like the osseo in this space and setting. Do you guys ever tap here? I don't typically tap, I will tell you, but the two anchors I have had break in I think I'm almost up to 800 anchors, but the two I have had that have broken have been both in this area. So I will tell you, if the bone is so hard that I'm like hitting pretty hard with the mallet, I will consider this is the only area, at least for me with osseo, in the shoulder space that I will consider tapping with. Any thoughts by either of you, gentlemen?
Totally agree. This is like we were saying before, this is where you're going to have that denser bone. And this is where I definitely would not under punch. And if you feel the need to tap, you're not giving up fixation strength by doing that. You're just hopefully not getting to that situation where you might put this anchor at its utmost risk of having a breakage, which so far I've not had. But I think I've probably done half as many subscap repairs as you, Nirav.
Oscar, your thoughts here?
So I haven't used it in arthroscopic subscap repairs, but in my total shoulders, when I repair the subscap, I've used osteofiber and I tap it. So
Yeah.
because it is very strong bone. So
Yeah. So here's kind of my post subscapular, right? You can see the tension come over. And the reason I like slowing this slide, right, openly is you can see actually the amount of tension through the anchor body you can pull over. It's pretty clear. You can see the advancement and actually the tear is now reduced back to the wall. So I think there's clinical utility. I'm going to turn it over. Ira, can you put up Oscar slides if you don't mind, please?
Sure. No
Thank you.
problem. Let me get that up.
And guys, while we're kind of addressing it, is there anyone on the audience or Ira, like I was looking through, I haven't seen on the chat, I don't see any questions, but if anyone does have questions while we're kind of transitioning over to Ira, it'd be great if you just put them in the chat, or you're more than welcome kind of towards the tail end, we'll kind of open it up. But as you can see kind of the broadband applications. Oscar's going to present probably I would say the novel idea that has really gained a lot of traction. So like I think when people are like, hey, what's OSSIO? How to go? It's gained a lot of traction in this space. Brian Cole has done a lot of nice work in this space, along with Ackerman and Sean Kelly and a bunch of early adopters in this space on the knee bar. So Oscar, walk us through this a little bit and I will kind of forewarn everyone. We had a nice knee bar kind of session with Joey that was dedicated to this. So I think most people may be a little bit familiar with knee bar, but walk us through kind of your thought process and where you are.
there we
Oscar,
go.
you're on mute. There you
Yeah, I was looking for the mute button. So this is a little bit we haven't talked about this yet, but basically the knee bar procedure is I'll take it right off the site. It's a surgical technique for the management of subchondral insufficiency fracture of femur and tibia. So basically what we're doing is we're taking those helical trimmable nails and we're using them on those subchondral fractures. So for all of you that are familiar with subchondroplasty, it's sort of, for me, the newer, better technique for that. And I was a big believer in subchondroplasty. I believe that the term lesion or those subchondral insufficiency fractures are pain generators, and I had really good success addressing them, but it did have some problems with it. The sort of the liquid calcium phosphate, whatever company you use, some of it would leak out. It would irritate the local tissues. Well, also, sometimes it would increase pressure in the bone, so you have people wake up with a great deal of pain, and we'll go over that. But when I first heard about this, I said, "Oh my goodness, this is for those patients." This was like the next generation, the evolution, the next step in this. And I really adopted it quite quickly. And I've been happy with the success. So this is a picture of those 4O cannulated trimmable nails. They come in large size. I think it's 100. And then you can cut them down to size. Brandon had talked about it. You can do it with a saw or sometimes with other devices. There's different ways to do it. And then you put it back on the wire to just sort of recannulate them, because sometimes with the saw you cut them and it can, but this is what it looks like. And it goes in, basically you tap it in to where you want it to go. Basically you put a wire, you ream, and then you put these in. Pretty straightforward, simple procedure. And then we'll go over this case. So you look at this, I have an 84-year-old. You're saying, oh man, Vasquez, you're showing an 84-year-old. Why are you operating on 84-year-olds? I've done plenty of these cases. I think I'm up to like 35, 36 up to date. So, but this was just such a good case that I thought, because this is a patient I knew forever. She's a Latin patient of mine. Not that that matters, but it never won operation. This is, and I treated her for years with NSAIDs, cortisone, hyaluronic acid. She had some mild early arthritis, and she was one of my patients that came in every 6 months. Past medical history, she's very healthy. hypertension, asthma, the awesome BMI. This is not what I always deal with, 22.8, non-smoker, non-drinker. So anyway, what happened was she had a fall. The fall wasn't anything big. She had some pain with it, and she comes in and she was due for gel shots, and I treated her conservatively like anybody else would. You got an 84-year-old lady, good health. She's walking. She just has a lot of pain on the medial side, but she's not on crutches, nothing crazy. And I treat her with NSAIDs, cortisone, but as time passes, she starts getting worse and worse and worse. And I mean, I braced her, PT, everything. She got to the point over 3 months that she comes into the office. She brings a walker and she gets wheeled in. It's killing her. And she's like, and this lady, I had wanted to get an MRI sooner because she was starting to, she wasn't going in the right direction. I said, something, I figured she had an insufficiency fracture, whether it was due to the fall or the underlying degenerative changes. In any case, this was first the X-ray. I mean, I think everybody could agree that you got a little bit of subchondral sclerosis, but there's a little bit of narrowing, nothing crazy, pretty good knee. I hope my knee looks like this at 84. And this is her MRI. So not so, and this is, whether this happened from the fall, but this is 3 months in. So, this lady now at this point is like, you need to fix this. So what do you do? I could have done, I guess, traditional subchondroplasty. You can consider this a full fracture. I guess if you're a trauma guy, maybe you open it up, put plate and screws. Obviously, I think that's crazy. But, I think this was probably in my early phase. And I said, this is maybe the perfect case knee bar, put strong fixation, you're putting in the pins, the helical nails, you get that strong fixation, decompress that area and support the bone. And if I had known this went so well, if I had known, I would have gotten videos of her before and then 2 weeks after. She quickly got better. It was so impressive. So this was the case, not quite rocket science, but you get a good view. I put this is actually two wires. I think you can kind of tell. I try to put them in parallel as best you can. I didn't take a lateral with the pins, but I was able to get good alignment right through the area where the insufficiency fracture was. Again, this is a picture of those helical nails, and then this is the immediate post-op picture. So you can actually see where the nails are, so you can pick them up. Not the best lateral, I apologize for that, but you can see sort of and that's how I kind of always do it, two parallel to sort of support the whole tibial plateau. Obviously, I adjust it based on where the insufficiency fracture is, if it's front or back. And, this is using the skills we've used from trauma and we use in sports. And it's not, pretty straightforward. I think pretty much the nice thing about, we're talking about implants, the materials, good technology, but also an important thing is, can everybody use it? Is it easy to use? Is it reliable? Is it reproducible? And the surgery is pretty straightforward. So I think this is, in my experience, I've had, just excellent. And 2 weeks out, she was walking into the office. It was like night and day. It was ridiculous. Like the family, I just saw her, like, I think she's like a year and a half or maybe 2 years since it's kind of probably a year and a half, something like that. And she, the family's like still talks about it and thanks me. In terms of post-op instructions, so what do I do? Some people are a little bit more, they use crutches or bracing. I actually kind of treated them like I did when I did subchondroplasty. Weight bearing is tolerated, and I start them on PT right away, almost like just a meniscectomy. I don't even brace them, and I do the routine pain medication, NSAIDs and such. And this lady's 84, so she's a pretty good test that I think the implants hold and I don't, some people have different techniques in that they go with the knee bar all the way across. I don't. I think you get plenty of fixation, just kind of getting across and into the lateral tibial plateau. But this patient did great, and I think this is something that I'm certainly using in the future, and I think other people will too.
Yeah, I mean, I think Oscar, it's a great job, right? Describing kind of new utilizations or platforms of the right material, right? Historically, obviously not, I think from a sports perspective, we're not going to put a metal screw across an insufficiency fracture, right? There's no healing in that metal. It's a fixation, but there's no actual biologic portion of it. I think because the material has an inductive property with the hydrolysis crossing over and creating the bone environment and milieu to remodel the bone. I think that's partially why a lot of these patients are feeling some level of pain relief over time. I think we're about 15 minutes left. I'm going to actually run through one of my slides.
Okay,
Um,
great.
and then what I'll do is I'm going to take the screen, I'm going to share, and then we'll go to, whoops, sorry, my Zoom. So as I said, guys, I'm going to kind of walk you through a little bit of a broad perspective, right, overall of, in the sports medicine side. I think it's really interesting. I think Brandon and Oscar and I will agree. If you're fortunate enough to have an all sports practice where you see nothing else but shoulder and knee, you're very fortunate in the world. But a lot of us have kind of a diversity. We're doing not only sports, right? We're doing Achilles tendons, patellar tendons, quad tendons, and other applications in sports medicines, along with some level of fracture work that becomes a reality. I call sports medicine surgeons somewhat a glorified general orthopedist. Maybe some disagree, but I think we have a vast variety of overall things. So let me kind of walk you through a little bit of this, and then I'd love to hear Brandon and Oscar's thoughts on this. Look, Achilles tendons, right? I think we all worry about the actual healing potential in that space dissection, right? So historically, what do? Open or percutaneous, you can get a sponsored study and put them all in a cam boot and do non-op treatment. I think, but then because of the Aaron Rodgers phenomenon, Kevin Durant phenomenon, you see people recovering at a really robust rate. And how do you get to that level? So I think let's look here. So let's say an open technique, right? You do a wide open approach. You look at the tendon, you get side to side repair. You get to this level. So like you have pictures coming in, right? Where you have this tendon, you can see it kind of pulling through. And then this pars came out. It's the market leader. It's a great application. Patients are doing really well with this. So how can we get better when it's a market leader and patients are doing well? Well, let me walk you through it. So I actually use an ultrasound. I use a spinal needle to shuttle my sutures through a contraption. I use a device that allows you to come in. So here's my actual incision. You could actually see this coming in. And then you say, oh my God, where is the incision? It's actually less. If you take your fingernail and you look down, it's half the size of your fingernail, right? So it's less than 5 millimeters. And the only reason that incision is there is you actually go in to put the device in to grab the sutures and pull it back. And then how do you fix it distally? So if you want to do a bridging technique, right, then you could see me drilling here on the left on the screen. You put the OSSIO anchors in, and now you have this, right? So this Achilles tendon openly was 3.5 months out. And the reason he was 3.5 months out is he had a tibial non-union that my partner was trying to fix. And so essentially he got kind of lost in the care. So he got sent to me. Over here, do better. Sorry, let me shut the volume off. Oh, that's weird. Sorry, guys. Oh, that's weird. Sorry. Essentially, that video, I don't know why it's not playing, but essentially, it's a video of him doing dorsiplantar and plantar flexion. The reason I like showing this talk is to kind of give you a diversity of what osteo can do, in what manner and what space it can do it in. So when you think about it, there's been a lot of us doing it in very creative models. I know Brandon used it for meniscal roots, correct? To do your fixation in. Oscar using it back up tibial fixation. You've heard us talking about the lateral row and the subscap. You see this Achilles going in, and then now you see Brandon and Oscar talking about applications of the nail going in for TTOs. Brandon, you alluded to Mike Freehill's data, really good on the lateral J's, right? And he's got a data set he's doing out of Stanford on lateral J's and fixation in that space. So there's a lot of nuances that are coming into that space in that setting. Right?
And even in additional is OCDs in the knee and elsewhere. For example, the compression screws. There's smaller versions of that. There's even smaller, like 2.4 millimeter pins. It's solid core. I've used them all those on several different types of OCDs, and it's great because again, that's not metal. You're near the joint surface. You don't want metal. I've actually had to take other surgeons' patients metal screws out. Also, like putting in wedge defect osteochondral allografts in the shoulder for big Hill-Sachs wedges. those compression screws were great there. I mean, if you think about it, if you take a step back, like where I'm using metal, can I use this, one of these implants? And the answer largely is probably so. It's just thinking it through. But go, yeah, this is a good one too.
Yeah, so like I would say I don't have the fortune that Brandon has of taking no call. I think I torture myself. Oscar, do you torture yourself with general call or no?
Much less than I used to. I don't take the level one anymore. I got community, but I still get what I'm looking at. I still get that. So
Okay,
I
so
guess
let's
the
say
answer is yes.
I do get this. I think the surgeon's on the call. I think if you're a lucky sports surgeon who don't take call, God bless you. I got to figure out how to get to that path. I just am not on that path yet. But let's say you get this case, right? So I think, Brandon, you made a really good point. I think in my mind now, when I say, okay, how can I fix something in the right manner? But how can I help the patient too in that space and setting? So let me walk you through this. Here's my actual image, right? So I plated the lateral fibula, right? And then you could see the medial mal coming in. And then if you look, I put two osseo screws up on the medial mal and held it in place. Now you may say, well, why do I do that? Very simply, right? Because I think if you kind of think about those parameters, I think we all will agree if you look at Furkel's data of the OCD lesions that are associated with ankle fractures. But if you have medial mal screws going up and you have a lateral plate going up and you get an MRI, you're going to get a lot of artifact. The one thing that's kind of understated by us is if you have bioinductive implants going in, you're actually not getting artifacts. So, Brandon, you talked about OCD lesions. Now, think about it. Let's say you do a cartilage repair with osseo, and now you're like, hey, they're still having pain. What do I do? If there's metal screws, you're kind of stuck, right? You got to go back. You maybe have to do a diagnostic arthroscopy. But instead, here you can get an MRI and get visualization and a value add. So I think like when we think about things, and I think we think about applications in sports medicine, because that's what we're focused on today. I think Brandon, you said it really well, and Oscar, you're talking about it too. The applications for this are really robust in nature because it's not actually specific to a surgical technique. It's actually a technology material play that expands to multiple platforms overall. And I'll share with you lighthearted, I do take level one trauma calls on this weekend. I had a 13-year-old that had a tibiotubercle avulsion fracture, and very openly, I used to put two metal screws with the washers as per my Pete's partners. So this weekend, I actually made a little incision and I used two 4 or 5 nails, like Brandon described, literally going across the back. And when you look at the tibiotubercle, the entire fracture is reduced. And I thought to myself, I told the parents, I go, guys, on X-ray, you're not going to see anything. I go, what do you mean? And I go, well, I use the material that you're not going to see anything. So there's so many applications in the pediatric realm and the trauma realm and stuff that we can go on and on and on. But I think the goal of this symposium, to be fair, right, is to have the openness to understand the material play. And if I can stress to you, if you're concerned about the material, try it on backup fixation for the tibia first, if you don't trust it. If you're a big TTO surgeon, try it on a TTO. Why don't you put one metal screw and put one osseo screw and just see if the material reacts the way you're hoping it reacts, right? And then transition over. No one's asking you to take the leap of faith and change your practice tomorrow. And but Oscar, we're kind of cutting close on time, Iris. So I'm gonna take closing comments from Oscar, then I'll go to Brandon, and then we'll kind of open it up if that's okay.
Yep, perfect.
Go ahead, Oscar. Take it away.
Yeah, so I've been extremely pleased using these anchors in the shoulder, in the tibia, repairing ACLs, and I've used in the fracture world. I did it for greater tuberosity fracture. I used to use metal washer, for those, and even I use it for greater tuberosity non-union, and it was compressed it, integrated bone, and it looked great. So I'm gonna echo your statements and say, give it a try. Give it a try in an area you're comfortable with. Start off in a lateral row, and you're gonna see that it works great. It's reproducible. It's easy to use, and then you get the strength and the integration of bone. I mean, who doesn't want that? That you don't have to deal with metal and that becomes bone over time. So God forbid revisions. I mean, I think the story tells itself.
Brandon?
Yeah, I mean, like with our fellows and residents, the biggest thing that I harp on when I tell them like what defines how I choose implants is what does it look like on the revision when I have to go back? Because at the end of the day, at some point we're going to do things that fail and we have to be prepared to take care of them. And using this material is leaving yourself a blank canvas, for the next go around when it comes. And, I think that's for me and my patients, it's really changed in that arena. And it's just the flexibility and the ease of use, but also being able to use it for so many different things. Where we used to use metal and metal used to be commonplace. I mean, again, this is disruptive to the market in the sense that this is a material that integrates and doesn't sit there and we say it's going to. So it actually does it. And the other thing I can't, we've all gotten MRIs with metal around the joint, and it's frustrating as all hell because it's naturally Murphy's Law that metal's screw or whatever is going to be, near the structure that we're interested in, and we don't have to worry about that anymore. Like we can get a clean MRI each and every time. So this is massive, and there's some other types of implants going to be coming on the market here, hopefully within the next couple quarters, a year or so. That's going to again be more disruptive. So this what you're seeing here in the portfolio is not all there's going to be. So it's been a lot of fun.
Yeah, and Brendan, I'll echo your statement, right, to close and turn it back over to Ira. I think the aspects of, right, some of it often is like, there's reps in the room and you don't want multiple reps in the room and so forth. But I would echo your statement of it's really important to understand the value add perspective you're giving your patient, right? Like thinking about the time you're putting an anchor in and it breaks, and then you put another anchor in and it breaks, and you're frustrated at that case, and half the material's in and now half the material's out. You won't have to worry about that level of frustration, right? And I think Oscar made a point earlier that said, hey, it's actually really easy. The eyelid hole is bigger than the other anchors on the market. It's easy to slide the sutures into it. It feeds really easy. I think you've mentioned before to me that you put in up to 8 sutures in there before, right? A combination of it. I think in the last part is to understand as a platform take, you're absolutely correct, Brandon, right? The novelty and novel approach to what the company is doing is very interesting, right? They started in foot and ankle. They migrated into sports medicine on the lateral row. Now they're in these niche products like Oscar's great talk on knee bar, your great talk on TTOs, and now they're coming into the bread and butter, right? In about Q1, Q2, they should have ACL screw fixation, right? And at that point, and your thoughts are, hey, can I now fix a quad instead of having an adjustable loop where I have displacement on the femoral side? Can I put a screw in with no displacement, right, on the femoral side? And or BTB where the screw's not breaking. I'm not worrying I have to tap. That's where the magic's really coming, right? And they're going down that pipeline. So I think stay tuned. I think the company's really evolving. They're really open to surgeon suggestions. Their leadership is excellent in nature. They want to learn. They want to learn this process, and they want to do the right thing clinically, right? They're very conscious of providing the right care to the patient at the right time in the right setting. And I'll close with that. Ira, let's see if there's any questions or chats. I see
Yeah,
there's
there's one there. Chris Easton is not in a place to ask on the phone, but he wanted to know, do you feel that there is less stress shielding in TTOs versus metal due to the inherent properties of OSSIO? And anecdotally, does that translate to better and quicker healing?
Yeah, I mean, I'll take that. I mean, I don't know the true answer to that. If there's less stress shielding, I mean, I don't know what the true elastic modulus of the implant is, vice bone. I mean, maybe if there's someone from the company on the line that might know that, they can answer. But I do think there's a component of it being biointegrative and not metal that might also translate to the better healing, and that's the bridging aspect of the implant itself across the osteotomy site or fracture site, however you're using it. And that may also kind of add to some of that early healing because there's definitely like a stickiness that absorbs stuff to it over that first couple weeks, and I think that that's happening in that early phase. And so that might have something to do with it as well.
Yeah, and I think Ira, the key parts to understand, right, is for me, like anytime you think about kind of an inherent property of a material, the key aspect is right when you're doing study parameters is the what does the FDA grant you, right, to stay and what not to say on a marketing platform, right? Because that's probably the most stringent rules that we all go by in the United States. And for the FDA to grant them internally, right, that it's an integrative material, it's kind of says volumes to show you the clinical value add perspective in this space. Because no other biocomposite market, in I would say, m- is able to market that term to their surgeon champions. I think one question is, what's the best way to focus on getting, that's interesting. I mean, I think the question is, how do you get a surgeon to pivot away from a competitive surgeon who's a heavy user? I think in reality, I mean, I think the question to get asked is if they're a heavy user of a competitive product, is if they've broken anchors, right? If they own an ASC, right, where they have a financial value add perspective of their ASC and their due diligence of their shareholders is to give value to their product. Now, if I'm doing a rotator cuff and I break a couple anchors, go back and look at how many anchors you actually break, right? And then if you can provide a material play that doesn't have that ability or doesn't have that high level of actual implant failure rate, then you've added that value, right? And I think you got to be honest with your surgeons. Hey, look, there's a new material on the market. Would you be interested? I think it's hard to switch everyone over. Brandon and Oscar, please jump in if you disagree. But I think if you think you're going to switch a surgeon over overnight and say, hey, are you going to take a switch over overnight? I think people are skeptical. They want to see the material behave in the appropriate manner. Now, granted, I think Brandon, me, you, and Oscar are kind of high volume users of OSSIO. We built our trust inherently through time, but it's not like in my first day in the OR, I just said, bring all OSSIO, right?
Oh, absolutely. Yeah. Skeptic at heart, skeptic first, and we should all be. And, and rightfully so. But, my old chairman said, don't be the first, but don't be the last to jump on the bus. And I think, yeah, I might have been on the early phase of that, but I don't, I don't, I don't, I don't regret it at all. I mean, I think saw something that I trusted enough to kind of take a shot at it, and it's not failed me. I've been very happy with it. My patients are very happy with it. So, I mean, I think yeah. I mean, as to get people to move away from competitor, you know, I don't know. They just have to kind of put it in their hands and just go, and they have to have a leap of faith. Maybe come talk to one of us. I mean, I'd happy to chat with anybody who's interested.
Yeah, I mean, I think it's kind of a directive, right? Some surgeons may not switch. I mean, but I think from our end, from anyone who uses Hasio and they have done clinical work with them, there's a big inherent trust of the material to date.
Yeah.
I would say have them watch this talk. I mean,
Many times.
all the things. Yeah, that's on you, Ira. Get it out there.
And I know
Um,
I've seen like a biomechanical like pull-out strength comparison to that competing product that Osseo has. It's very compelling,
Yeah, it's
um,
published, right?
very insightful.
It's
I
from
don't know if it lives on LinkedIn or YouTube somewhere, but it's the pull-out resistance is definitely outperforms the other competitor product as well as torsional strength. So yeah, without a doubt.
Yeah, if you believe the science, right, Brandon? I mean, that study was done at CSU, right? And it clearly shows the actual ability of the anchor to tolerate what kind of loads of it, kind of having some level of it being compromised in a level versus the osseo. So I think it's dealer's choice, but I think you got to go down the science route,
Yeah.
the purist. All right, I think we're close on time, right? A couple minutes over.
No,
So
we're good. We're good. As I always like to say, this is the fastest hour in orthopedics. I'd like to make just a comment, which is so amazing, which this product demonstrates. I always like to feel that my litmus test for a truly disruptive product is that if you think of it, if this product came out first before all the other products that it's substituting for, would you ever make those other products? Would you ever now make certain metal, if you were repairing an ACL, would you make a metal screw now? And that to me is a litmus test of a truly disruptive technology that if it came first, you would never even think of making the stuff we're using now. And I think that came across very clear to this whole group. I also want to say that the journal has made a great arrangement with ViewMedi. So starting in a couple of weeks, all of our videos from these topic sessions will be available on our ViewMedi channel, not only our YouTube channel, but our ViewMedi channel, which I think gets a lot of traffic. Not as much as Joey does. No, no, it gets a lot of traffic. And I really want to thank this great panel. Um, Nirav, Amin, alumni of many Joey sessions. Oscar and Brandon, thank you for your first time here. This has been a great session. Great technology and great questions. So I want to thank everybody and say good night.